This video we are going to see about myofascial pain dysfunction syndrome. So myofascial pain dysfunction syndrome or MPDS is a disorder or dysfunction of the masticatory muscles and characterized by dull, aching, radiating type of pain in the myofascial structures and in the head and neck region. So this was first described by Laskin in 1969. He proposed that it is a psychophysiological disorder because it is aggravated by stress and that leads to myospasm and resulting in myofascial pain dysfunction syndrome. Coming to a etiology and pathogenesis of MPDS. According to Laskin's theory or psychophysiological theory, muscle spasm is a factor for MPDS. Any emotional factors that is stimulating the chronic parafunctional habits like grinding, bruxism that eventually results in muscle fatigue and myofascial pain dysfunction syndrome. So these are the listed etiological factors. First, occlusal disturbances, and two, intracapsular disorders like any TMJ disorders, and third, emotional turmoil, that is emotional disturbances like stress, and fourth, parafunctional habits like bruxism, and fifth, if there is any direct or indirect trauma to the TMJ. Coming to the pathogenesis of MPDS. The pathogenesis that is proposed by Lerman holds that MPDS results from an interplay of unbroken chain of etiological factors. So when there is any etiological factor that were mentioned above can result in micro or macro trauma to the musculoskeletal system or masticatory muscles. So that results in muscular spasm, which increases the tonicity and muscle fatigue, which results in hypoxia and accumulation of metabolic byproducts like lactic acids and increase in prostaglandins, bradykinins and histamine, which increases the pain sensitization or lowers the pain threshold, which eventually results in myofascial pain dysfunction syndrome or muscle pain. Simons also presented an hypothesis on myofascial trigger points and explaining the persistence of pain in myofascial pain dysfunction syndrome. So he discovered that it's a six-linked process which starts with the abnormal release of acetylcholine, which causes increased muscle fiber tension in the muscle, which is seen as a taut band when we are palpating the muscle, and this taut band constricts the blood flow and resulting in a local tissue hypoxia. So this reduced oxygen disrupts the mitochondrial energy metabolism, thereby reducing the ATP and leading to tissue distress, which releases certain sensitizing substances, that is prostaglandins and bradykinins. So these sensitize the nociceptors and causes pain and tenderness in the muscles. So which again lead to an autonomic modulation and which increases the abnormal acetylcholine release. So myofascial pain dysfunction syndrome is a vicious cycle. Starting with the abnormal acetylcholine release and resulting in pain and tenderness, it again causes autonomic modulation and abnormal acetylcholine release. So breaking this vicious cycle is ultimate strategy for therapeutic management of myofascial pain dysfunction syndrome. We keep talking about trigger point and taut bands in the myofascial pain dysfunction syndrome. So what are these trigger points? So the development of trigger point is considered to be one of the most important characteristic feature of MPDS. So the trigger points are nothing but a small tender areas within the muscle from which their pain is transferred or referred to a different areas or distant region. So this referred area is called as referred pain zone. So the identification of this trigger point and referred pain zone is very important in diagnostic criteria of MPDS. How is the trigger point is formed? So in a muscle fiber, when the muscle is fatigued or taut, within the muscle fiber there will be formation of contraction knot. So this contraction knot only result in hypoxia to the muscle, which eventually causes myofascial pain dysfunction syndrome. This point is called as trigger point and this complex or taut band is called as trigger point complex. These trigger points can be formed due to change in pressure or any movement or any physical or emotional trauma that all results in the formation of contraction knot or taut band, and that results in a trigger point activation and referred pain zone and eventually resulting in a myofascial pain dysfunction syndrome. There is another one terminology that is usually discussed in myofascial pain dysfunction syndrome, that is nothing but tender spot. So what is tender spot and difference between trigger point and tender spot? The trigger points differ from the tender spots in the sense that the pain from the tender spots are localized in the within the spot, while the trigger point refers to the distant area. That is, trigger points can refer the pain to a distant region, but tender spots, the pain will be localized only to that area. However, the treatment of both trigger points and tender spots are exactly the same, but only the terminologies differs when we diagnose the patient. Coming to the clinical symptoms of myofascial pain dysfunction syndrome, starting with the pain and discomfort to the musculoskeletal system of head and neck, and limitation of the jaw movement or any deviation of the jaw movement is present when examination, or the patient itself will tell you about this. And there will be joint noises like grating, clicking or snapping sounds will be heard when the patient is opening or closing the jaws, and tenderness when it is present when you palpate the muscles of mastication, like when you palpate the masseter, temporalis, lateral pterygoid, there will be tenderness present during the examination. Patient also complains of neck muscles pain and occipital region pain in case of Mpds syndrome. Diagnosis of Mpds is done with the following sequence. First, history taking of the patient, how the pain is started, and when it is aggravating, when it is relieving, and any referred pain zone is present. So all these gives a clue about Mpds diagnosis. Second, physical examination of Mpds. So physical examination includes evaluation of the entire masticatory system along with the head and neck region, and amount of oral opening, and what is the range of motion, how much is the active range and passive range of motion should be examined, and palpation for the tenderness, any tenderness present in the preauricular region or within the external auditory canal when the patient is opening and closing the mouth. So all these should be examined in the physical examination. And the grading of clicking or crepitation, if at all present, that all should be examined in the physical examination. Third, which is very important, muscular examination. So systemic palpation of the muscles and their tendons are the best way to diagnose the Mpds. So the areas responsive for palpation is called as trigger point. That is what we studied in the pathophysiology. We have to identify all these trigger points and their referred pain zone with the help of muscular examination. So the muscles of mastications are palpated bilaterally and simultaneously with a firm but gentle pressure that is lasting for 1 to 2 minutes. So where and all we should examine? So initially it is starting with the lateral palpation of the joint, then within the external auditory canal, then the masseter muscle should be examined, then anterior and posterior band of temporalis should be examined, then vertex of the skull, then occipital region. When the patient presents with pain in the neck, we have to examine the occipital region and neck region. Then we have to examine the sternocleidomastoid region. Then intraorally we have to examine the medial pterygoid at the angle of the mandible. Then posterior digastric and lateral pterygoid at the maxillary tuberosity region. So all these areas should be examined, and identifying the trigger point and their refer pain zone is very important in case of muscular examination. Then coming to intraoral examination, examination of the occlusion, occlusal pattern and their attrition. If there is any presence of parafunctional habits like bruxism, should be identified in intraoral examination. Then radiographic examination to identify any TMJ abnormalities or intracapsular disorders like TMJ osteoarthritis or any arthritis, rheumatoid arthritis that is involving the TMJ that is causing the muscular pain should be identified with the radiographic examination. So radiographic examination includes panoramic radiography and tomography. Then we can go for CBCT and CT, and MRI is used for articular disc damage or articular disc degeneration or displacement can be identified with an MRI. And at last, as I said, it's a psychological disorder. Psychological evaluation should be done for a patient in order to identify the emotional cause. So based on that, Laskin devised a diagnostic criteria to diagnose the Mpds. So he gave 4 cardinal or positive findings that should be present when we diagnose the Mpds, and there should be 2 negative characteristics that should be absent when we diagnose the Mpds. So the 4 cardinal signs which he represented was unilateral pain and muscle tenderness, particularly to the masticatory muscles, and clicking or popping noise in the TMJ, and limitation of jaw movement. So these are the 4 cardinal signs that should be positive. And negative findings like no radiographic evidence, that means there should be no TMJ abnormalities or intracapsular disorders, and no tenderness in the TMJ area on palpation via the external auditory meatus, not the lateral palpation or preauricular palpation. Via the external auditory meatus, if there is any tenderness, there should be we should think of intracapsular disorders, then myofascial pain. So these are the Laskin's diagnostic criteria, but not all myofascial pain dysfunction syndrome obeys this criteria. We should identify all the tender zones and tender points and then referred pain zone. Then we have to abide the Laskin's diagnostic criteria. Then we can diagnose the Mpds. Coming to the management of Mpds, so it is divided into non-surgical and surgical management. So non-surgical is first considered in management of Mpds only as a last resort. If all the non-surgical procedure has failed in treatment or if the case is recalcitrant, then we have to go for surgical management. So non-surgical management includes first patient education and no measure. Each patient should be made aware of the relationship between stress and muscle tension. So resting the jaw is possible by making the patient aware of their unconscious postural, swallowing, clenching and grinding habits. And it also can be coordinated with splint therapy. And elimination of hard and chewy food helps to reduce the loading force to the joint and rest the hypertonic jaw muscles. So diet also should be monitored. Relaxation therapies like yoga, meditation also helps in the management of myofascial pain dysfunction syndrome. Along with the education and home measures, pharmacological agents like analgesic drugs, anti-inflammatory drugs and muscle relaxants helps in achieving the muscle relaxation and relieving the pain. Other therapies that are used in the management of myofascial pain dysfunction syndrome includes transcutaneous electric nerve stimulation, that is TENS. So it is based on the concept that stimulation of the afferent cutaneous fibers of the fifth cranial nerve creates an inhibitory effect on the descending pain pathway. So it's like a gate inhibitory theory which helps in relieving the pain and also indirectly induces the muscle relaxation. Other non-surgical therapy that includes the management of myofascial pain dysfunction is dry needling. So dry needling is a treatment that involves a very thin needle being pushed into the skin that stimulates the trigger point and helps in relieving the trigger points. So and other therapies includes physiotherapy and massage therapy or deep pressure massage therapy and stretch therapy with a after cold spray. If all the mentioned non-surgical therapy has been failed and if the case is recalcitrant, then we can move on to surgical therapy. So surgical therapy includes condylotomy and myotomy. So surgical therapy is usually considered as a last resort in the management of Mpds. That is all about Mpds that you need to know. Thank you.